Dr. Thomas. So good morning, everyone. Welcome to our Department of Medicine Grand Rounds. My name is Garrett Greenberg. I'm one of the internal medicine chief residents this year. And it's my pleasure to introduce today's speaker, Dr. Africa Stewart. Africa Stewart graduated with honors from Johns Hopkins University in 1995 with a BA in Psychology and Mathematical Science. She then attended Drexel University Medical School in Philadelphia. In 1999, she completed an MBA with a concentration in strategic planning from the University of Pittsburgh's Katz School of Business. Then returned to Philadelphia to finish her medical training at Drexel. In 2000, Dr. Stewart received her MD and started her residency in OB/GYN at the Hahnemann University Hospital. Her career with Doctors Without Borders, or MSF, began in Sudan in June of 2011. Dr. Stewart has completed 5 surgical field assignments with MSF and served as a guide for the organization's First From Home exhibition about the global refugee crisis. She was elected to the board of directors in 2017 and is currently the president of MSF. She continues to support women's healthcare locally and abroad with an emphasis on education and prevention. Dr. Stewart, thank you so much for taking the time out of your busy schedule to join us and teach us today.
I am glad to join, but you speak it very well. This is a busy morning. I am at home in the Old Fourth Ward in Atlanta. So I live down the street from MLK's home, but our headquarters are in New York. So I'm back and forth a lot. And today my son has a track meet. So it's just one of those mornings. I'm so glad to join you virtually. I don't think I can wrap my head around a New York commute this morning. Especially since I have been traveling and there is this balance in this role that's sort of somewhere between like, don't waste the fuel, but show up if you can. You know, I'm constantly at odds at those. So I used to tell my residents that never wake me up, but if you wake me up, I'm coming. Like I'm coming. So I'm somewhere in that world with my kids of sort of, I will go if I have to, but if I don't, then me and you all and our dog is just really put off by this change in the morning routine. But part of my joy and my privilege in this role is I get to pick and choose in a way that I don't as a field OB/GYN. I get to visit projects, things that I want to see. And in some ways, I feel like in leadership, there's a mandate to see it with your own eyes every now and again. So I spent some time this summer in one of our Kenyan projects. And then I just got back in time to meet with you all and sort of get my bearings from Malawi. And I wanted to speak about how they are so different from what people expect of MSF, but also where the thread that ties it all together, which is mental health in our world, as a new piece of the conversation of what humanitarian work can and should look like going forward. And because we have this storied path, you know, it also comes with these expectations. And in my role as president, I'm sort of trying to sledgehammer some of those down, that there won't always be soft music and an awesome slideshow of our projects, because some of these projects, as we'll talk about a little bit, are rooted in hyper-local sexual violence care. They are rooted in hyper-local mental health care, such that they'll never be the patients that we send a photographer and the editorial team to put together a package, but they are at the heart of the work that we do. So in some ways, I'm super proud. I really am. I can gas up a jet that's an ICU. We have inflatable ORs. If you turn it, it fills up with air and it's sterile in there. We have, you know, innovations in malnutrition. I mean, we've done some things that I am proud of, truly. But at the heart of our work is our local colleagues. We are, for the most part, we have 70,000 employees worldwide, and approximately 90 to 85% of them at any given time are working in their local communities. They are commuting across front lines. They are seeing their neighbors and friends when they go to work in the same ways that we do. So I really want to be able to speak to the parts that aren't out there on the internets when you Google us, but the thread that runs through them and the part that I'm most proud of and the pieces that I wanted to see with my own eyes in Kenya and Malawi are the pieces that are hyper local, that really focus on dignity and local psychological safety, because that is sort of how we're learning to build humanitarian care these days. So I'm super proud of those inflatable ORs. No kidding. It's amazing the first time you see one. But the project that I just came from most recently in Malawi is a different one. First, oh, and I put in the chat the international report, so you can like go and see stuff and there's stats and it's super nice and it does all the countries and stuff. But it's a little overwhelming, but I did want you to have a resource that you can sort of click through because the links and all of that are really interesting and it's at the heart of what we do. So Malawi is on the eastern coast of Africa, on the southern region. So it's it is viewed by Mozambique. So you could be in Mozambique, cross the border, be in Malawi, and then like 45 minutes later, you'll be in Mozambique again. So it's on the eastern side of Africa, and it is unique in our projects, one, because it has a palliative care piece of it, but also it's unique because it's in a non-conflict zone. Like there isn't an active conflict. There aren't the sort of safe houses and safety and security protocols that we'll speak about in some of our other projects. So it's different in that way, but it's also extraordinary in that it is a project that begins with screening at the community level and ends with home-based palliative care for cervical cancer patients. And throughout it is none of the things that we're known for, except maybe a lot of comprehensive HIV care. Granted, that's sort of our thing. But as we speak about the newness and the future of humanitarian care, I am reminded of the vicious verbal banter that happened amongst us MSFers as we started talking about doing HIV care in the 90s. There were people who swore that's not us, it's not what we do, it's not emergency. And there were other parts and factions of us that said, no, but they are patients and they need us. And our mandate is those who need us most, and these patients do. We have to adapt. That is similar to what we're doing now, which is adapting to conflict zones, because so much of what we do is in active conflict zones that a lot of times only thing we can do is train mental health officers to comfort and treat people who have arrived in displacement camps, that people ran from somewhere and managed to get here, and the weight and the compromises that families have to make in order to get to those camps is heavy on them. And sometimes that is all we can do because there is too much else going on. But as we get better and better at mental health, I want to shout that as a piece of our work that has always existed, but it needs to have a light shown on it, one, so that it is more and more widely accepted, that our donors and our volunteers expect us to treat our patients with a level of dignity and care that is part of mental health, that is part of these extraordinary circumstances. Sort of the reason that Doctors Without Borders is there is the reason that this place would need local, comprehensive mental health care. So we're seeing ourselves that way, not just water and sanitation where we arrive, but mental health officers that are local, so that you can, one, have the mental health reprieve that you need, but also to hear it in your own language, to be able to express yourself in those nuanced ways that feel like you might get home one day. So that is sort of how we are pivoting. So I wanted to speak to that. So one of the ways that we are doing that is the comprehensive nature of this project in Malawi. So it started, we were there during National Cervical Cancer Day or World Cancer Day. I think it was one of those in February. But because it's rainy season in Malawi, they tend not to necessarily celebrate it then. But it was a chance to put our minds towards the comprehensive nature of this project. Sort of where are those gaps missing? Can we be better suited? I was also there to see the projects that are community-based around sex workers in Malawi, keeping them safe, dealing with sexual violence in that community, keeping seronegative sex workers, making sure we have PrEP available, make sure that we have ARVs for those who are already positive. And that is another piece of this community-centered, patient-centered care that we are leaning into as an organization, and certainly those of us that are involved in women's health. And in my world, women's health almost always includes sexual violence. That piece of our work that is never going to be publicized, but is always prevalent. Where there is conflict, there will be sexual violence. Where there is sex work, there will be sexual violence. So from as colleagues, I'm sure you can appreciate that there is a part of our work that is sort of not just the obstetrical care, but just the treating of vulnerable patients as conflicts arise. It is part of what we have to do and what we have to plan for, but we also are learning that that can and should be community-based. So that was the other project that I visited in Malawi, just more out of curiosity than due diligence or good governance. I really wanted to see this project live. So this project starts just after dawn because sex workers are finishing their work and they're going to nap and rest and take care of their children when the sun comes up. So we do most of our screening and treatment of the local sex workers at the early part of the morning. It's just like pre-rounds as a resident. It feels very, very sort of making sure everybody's here. Is there anybody that was missing? Going through last week's ledger to see if there was someone that we were worried about that isn't here, and also giving priority to those that need urgent care or need urgent mental health services. And I watched the president, the vice president, the secretary, and the treasurer of the local sex workers organization pull out their ledger and go through. They had just had a death in their community, and they were sort of talking amongst themselves about how to be supportive to their fellow coworker, how to be supportive to her other children. And it was a marvel of the sort of thing that would be hard to explain if I hadn't seen it myself. But pregnancy tests, making sure there are condoms and lubes, making sure the sex workers who are HIV negative remain HIV negative, using emergency PrEP, making sure those who have already converted have their meds and access, and then also the rest of their health care and the confidentiality and the mental health support that comes with these pre-dawn screenings every other week. It is the piece of our work that I am proud of, that is built around adult sex workers and then modified for teen sex workers in that same area, with an emphasis on making sure they don't seroconvert because they are young and it's hard for them to imagine that they'll ever be anywhere else but right here. And the older retired, or they have a term for it, I won't use it, but not necessarily active sex workers, but in some ways it supplements income throughout one's life. But they are adamant on had the teens, the younger sex workers sort of having their own space and having their own counsel. But they are very, very clued into the things they wish someone had told them when they had to start this life. And hearing it from their voices and seeing how a project that was set up from older sex workers for the young ones, I never would have thought of probably, 40% of what exists and is necessary and makes only the most sense if you're a part of this community, that is the work that we are trying to amplify in the ways that are appropriate, but also to support, to make sure that this is a community-based organization that will survive, because they are committed to each other's safety, but they need medical support. They need medical support in ways where they can, in ways and places where they can be safe. And yeah, I'm the president of Doctors Without Borders. I can do that. So that was my trip to Malawi. So I'm going to pause there because I want to pick up that same thread, completely different part of the country. Again, a not conflict zone, but a place that has rampant acute malnutrition, that in the ways that are sort of cyclical and seasonal and unpredictable at these places, especially as it comes to the unpredictable nature of our oceans. So Kenya is another East African country further north, but it has a coastline. So it has a piece of it that's mountainous, and you have the safari part, and you have the East Coast. And if you're looking for an amazing vacation, the East Coast of Kenya looks like a Fiji screensaver. It's amazing. All right, so, but Kenya is a different kind of project. It's a larger country. We've been there since mid 80s, sort of on and off and whatnot, but it is a lot of women's healthcare as well, a lot of sexual violence in poor areas. And again, there are HIV protocols. Kenya is one of our flagship sort of shooting for 90-90-90 in terms of who's been tested, who's been treated, and who is on ARVs. Kenya is, if you Google Kenya AIDS 90-90-90, you will see the work that seemed impossible in the early 90s when we were trying to figure out how to be of service in the AIDS epidemic. So the project that I visited there is, again, community built. So in some ways it has a bunch of parts that don't necessarily go together until you get there, and it makes all the sense in the world. So I went to visit the sexually based violence, gender-based violence care unit. It is if the compound is a big quad, it's the innermost part of the project, so that it's quiet, it has sun access, and it's safe, because of the nature of the patients, but also sort of how the building was built. And I went to visit it because, one, it is another one of these community-based projects. It doesn't have anything like a project in the middle of a conflict zone has, which is where most of our projects are. So there's a little bit of cut and paste when it comes to a conflict zone. This one is so different. Even the buildings are different, but it also is different because it has a hotline. It has an ambulance service, so it has sort of urgent, emergent care. And then the innermost part is sexual violence. And I was moved by this project, and it weighs in my mind because I am, when the president comes to visit, it's sort of a big deal. So we were trying to be unintrusive, trying to sort of respect the space that we were in. So we did a modified version and just sort of visited with some of the staff and stayed out of the way. And one of the people that I wanted to talk to was new to MSF. She had sort of left the Kenyan civil, their teaching hospital not too far, a huge place, and come with us. So I was curious of what it's like to be a new employee, but also the work that she's doing as a counselor with, patients, which is why it was hard to see her, because she was working. So as she finished, they called us back because we're sort of in a different part so that people don't run into a camera crew as they're seeking this particular service. So, thank you very much. It's a pleased to meet you. Bang, bang, bang. We sit down, and the door to her office, she had sort of moved to two chairs, and there's a desk, so she's on one corner, and we're talking, and I'm asking the questions, and we're doing the thing. Out of the corner of my eye, the rest of her office, like now I'm in the room, and there are pediatric chairs. And it caught my eye because they are yellow, blue, and red. They are the chairs. If you've been to a parent-teacher conference when your kids are little, you just sort of, there aren't any other size chairs, so you sit in these tiny chairs. And I'm talking to her, and I realized what I saw earlier, like how many single-digit age of patients in the ledger that I saw. And our sexual gender-based violence counselor has tiny chairs in her office. And it hit me like a ton of bricks in the ways that it shouldn't. Like, this ain't my first rodeo. I just sort of forget. And I have the privilege to be home in Atlanta where my children are safe. And 40% of the sexual gender-based violence patients can sit in a chair that small. Like, this is a project I need to see with my own eyes, because this is a project that will never lose its funding. It is so unique. It is so well done, and it serves a need that is difficult to imagine if we aren't there. And it always is that way. That is the nature of my work. You know, if they say if you start crying on day one, you never will stop. But pediatric chairs in that clinic mean something. And the mental health care, which is what I was talking to the staff about, that is why they stole this woman from the big hospital, because she loves this work and their part was closing down. So someone on our staff who knew that she was there offered her a job that they didn't know it actually existed because they didn't want her to be lost. They wanted this community to continue to benefit, to make sure that piece of sexual gender-based violence has the mental health counseling that is appropriate and kind and dignified. So I'm sledgehammering an inflatable OT to bring the truth of our work. When people ask me about Ukraine, I tell them, no, I don't need you to donate gauze. What I need is the logistical support to get post-rape kits by the pallet over the border before dawn. That is the work I'm doing. Thank you for the offers of trauma-related, but in a lot of ways, Ukraine was prepared. They have trauma surgeons, they have trauma bays, they have hospitals that can cover it. They're still doing level 1 in active zones. What they didn't prepare for or even logistically think of was the need for sexual and gender-based violence in acute conflicts. It is in a lot of ways as prevalent as high velocity wounds in terms of conflict zones. So it gives us an opportunity. I'm hoping that your Department of OB tuned in, and that is the piece of when I'm recruiting OBs of, yeah, I'm glad you can do the things you do in these high resource settings, but I also need you to do those things in low resource settings under extraordinary mental health conditions and really be that kind of doctor. So to be shooting to have great hands, but also to know when to put them behind your back and just sit still and listen. So that is the work of, I used to think I had great hands, but it turns out it's just part of it. It is really an opportunity for us to reflect on how much mental health care we've always been doing, and then to see ourselves in the future of doing more, because that's going to be the work. That is going to be the piece of, certainly in humanitarian work, of learn to talk to the translator, learn to ask the question a different way, because culturally speaking, you may never get the answer that you need if you don't figure out how this culture approaches those very difficult, very violent, shameful pieces of what we need to know in order to do our work. So that is Oh, where are we on time? Ooh, I was shooting for 30. Okay. So I'll try to wrap up a little bit because I want to give an opportunity for us to talk as colleagues and sort of I imagine this as a dinner party that we don't get anymore. Partly because I don't wear pantyhose. I left them pre-pandemic. They're pre-lockdown, but there is this opportunity from time to time as colleagues to speak about the work, but also speak about what undergirds that work and keeps us strong to continue to do the part that we were trained to do. We were, but to see ourselves in the future as not just women's health practitioners, not just that primary care piece that we are growing into in the last decades or so, but also as mental health practitioners, as a resource for those who are carrying something really, really heavy. They're hoping someone will ask in a place that is psychologically safe and dignified. Because I'm doing the same thing on other continents with no scopes. So I'll stop there. Is there anything? I saw something flashed up on the chat, but I am glad to answer questions, or if you brought a question with you that I didn't touch on, I'd be glad to.
Great. Thank you, Dr. Stewart. So I welcome questions in the chat. I was curious, Dr. Stewart, I was thinking as you were talking so much about the mental health component for all of our disciplines, are we getting enough training in mental health, regardless of our discipline, whether we're OB or medicine or, are we getting enough of that as we go through, if you're not in a psychiatry program?
Exactly, and that is a piece I think of imagining our future selves, of where would our training meet with that, and also how do we interact with future patients in addressing those needs that have yet to come to us clinically. So I think we had one of these moments with COVID, sort of how to effectively communicate, how to as a body of clinicians make sure that we are on the same page and relevant and of the now. And I think that is a similar challenge. It's at least in my world, a similar challenge to link those clinical pieces together, especially when you don't speak the language. And, in some places, I'm obviously not from here, and that is a question of self-reflection myself, of whether or not I'm answering those questions. And as a leader, am I creating a space where day-to-day field clinicians can ask and answer that question for themselves? Anything else? Okay.
Looks like we do here. I can
Okay.
facilitate here. Related, this is from Dr. Katz, related to the question that I just asked, what mental health training do your staff and volunteers receive in the context of sexual violence, and or are you working with the usually very scarce local mental health workers, providers in these different settings?
I'll answer the last part, yes, because the answer is yes. There's a scarcity, which is how we sort of came to ask the question differently, because what we were looking for in our humanitarian minds is sort of where can I recruit? Where, what can I, nursing school in London or maybe Puerto Rico? And instead of looking out, we started looking in. And a lot of that mental health care training is coming from expats here or there, but we are training the locals. So in refugee camps now, and certainly displacement camps all over the world, the majority of mental health officers will tell you, I arrived here X number of years ago or months ago. My children were born here. I am doing a service to what is now my community. So we are trying to sort of get out of the model of who can we fly in, and instead, who can we train for a couple of days a week? Who can, because we have a lot of skill sets. People who are displaced had skill sets before they ran for their lives. So we're really looking inward, because the hyper local piece, the accent the pieces of culture that are invisible until they're gone are super helpful when it comes to the difficulty, and it's certainly with sexually based violence, but certainly there are other forms of violence that are encountered along some of these dangerous routes to safety. So we are aligning ourselves with the same sort of thought process.
Gotcha. There's another, thank you. Another that says, thank you so much for the great presentation, Dr. Stewart. I had a question regarding stigma surrounding mental health issues and sex work, and how your team has overcome those stigmas to connect with patients who may typically shy away from talking about these topics.
Same approach. Find the aunties, find the community leaders. We have a project that is multifaceted, and it covers a really violent area in Somalia. And as when I talked to him about it, I'm like, how does it work? How does it work? And he said, we meet with the moms and the aunties every other week to make sure that we're covering what the community needs. And I'm like, that doesn't seem like the answer to the question that I asked. He said, well, that's the thing. If you're in good with the aunties and the moms of the community, you're in good. You know, like no harm will come to you. But also you get the hyper local, you get the sort of everybody knows so-and-so needs help, but she won't take it unless it's, you know, under these circumstances, you know, sort of speaking to the culture of here. And that is very much how we deal with the stigma of trauma and pain when it comes to mental health, because we treat it like healthcare. And in some ways, that piece of dignity and psychological safety, that space that you want to create to talk about anything, it works in the same way of there's a dignity and psychological safety to talk about anything. So as difficult as it is for torture victims in Libyan prisons to sort of explain what they did so that we can make sure we're palpating correctly, I think the mental health approach is very similar of what is it that weighs on your mind so that I can be sure to palpate correctly in those same ways. So I think as we talk about our future selves, I would like for us to be the champions of mental health. I'm trying to think, is it as difficult as discussing an annual rectal exam? It's embarrassing and it's weird. We train for it. And it can't be any different. Otherwise, we are lacking in our service to our patients, but also we are doing them a disservice in teaching them to keep it quiet a little bit longer. That if we don't necessarily get them to open up, what we're doing is normalizing that door is open, and we may not be the recipient of that trust, but we can make it a normal thing that you should expect to have time with your doctor to discuss something that is difficult to say. You may not need it this time, but you should expect it next time. And I'm creating that space on purpose. That is a part of, I think, our leadership and our commitment to that safe space.
Gotcha.
Okay.
And another question from one of our other chief residents, which seems very appropriate here, besides thanking you for your talk. He says, for all the trainees on the call that may be interested in global health and our MSF, how did you end up finding your passion, and how can some of us contribute to these amazing efforts now or later on in our careers?
Crack. I'm glad you asked, because this is really just an elaborate recruiting trip for me. It's a delicate ruse. I would say the answer is train well, do your boards, because you should expect to be alone. It is possible that you may be the only you for miles and miles and miles, or there's a crew of the three of you and you're rotating so that you have proper rest and proper self-care. So I would say that in some ways, I wish I had known about humanitarian work sooner. but I don't know if I could have gotten there any sooner, if that makes any sense, because I think there is something to be said for the confidence and the certainty of your training, that it really is a piece of that fresh out, ready to conquer the world. So I spent some time, I finished my OB residency in '04. It's a shame. I almost needed my fingers. I was kidding. Yes, it was. So it's in private practice and having my babies and nursing and making milk and doing the whole thing. So my first assignment was 2011. My oldest was in ninth grade. My youngest was in diapers still. I left in the spring. She turned 2 that summer. So we were we were a young family, but it was also the piece of sort of finding the part that I loved, which was so different than private practice, and having felt like there were only 2 choices, that you were either in academia or you weren't. It was it was the sweet spot of not having to get up and go somewhere every day at home, but then having these blocks of time where the only thing I'm good at is the one thing this area needs. That was a relief that I didn't see coming. I thought I was going to do one. I hadn't done orientation. I was sort of in the process of signing up to be a Doctors Without Border, but there was in Sudan at the time, there was about to be a secession. Sudan became 2 different countries. So I was there to sort of cover that period that they were expecting a lot of trauma. And the poor trauma surgeon nearly died of boredom, because it was just pregnant ladies crossing the border because they realized that the maternity hospital was on the other side. And when moms and babies are crossing the border, the conflict sort of died out. So we pivoted. So that was my first assignment. I hadn't really started. Hadn't had any paperwork filled out. My kids were small, but we had a couple gallons of breast milk in the freezer still. We figured out how to make it work. And as my husband is want to tell, I felt different. I felt like this is what I'm supposed to be doing. Like the thing I'm good at, I could do all day, take a nap and do it all day the next day and love it. It was just what I had been hoping for. I should say my mom was a scrub tech, so I grew up in the OR. I was glad to just stay in there. And I didn't speak the language, so there wasn't that sort of outward facing part to my work. It was somewhat insular, and it did a community a great deal. And at the same time, I was training other surgeons and learning the need for an operative skill set for gender-based violence. And I thought, well, I'll just come back and learn a little more. I just want to be able to help out, one of these days when I do it again. And well, here I am. So my children have been on I think all of them have been on all but one has been on 6 continents, because we just make it work. Sometimes you got to roll with mommy. We're going somewhere. We'll be back in a few days. So I'm not sure if that's the answer to your question, but I think what I would like, the advice I would give to you trainees is get good, get certain, and then get going. Because what I really need is that independence. What I really need you to do is to be able to do it in a safe room for 2.5 days, because we can't leave. And then stock up, reassess, check on your colleagues, and see if you can do it again. But it does take some inner strength. And certainly from a career standpoint, just a practicality of, there was a time where I couldn't get a letter of reference that was written by someone whose first language was English. And I was like, oh man, I'm gonna mess up my career. You know what I mean? And what instead I found is my colleagues, just that little other box. I just said, well, what the form doesn't ask is, I've been in a little village east of Darfur that, um, yeah, I haven't had a real toilet in 3 months. I'm just glad to be home. I'm sorry I don't have anybody. I can translate the letter though. It says that I'm welcome back anytime, and that really helped me figure out what I was going to do because I had to read a letter from my colleague from afar that says that lady's welcome back here anytime. I thought, okay, maybe we'll be a weird family that travels a lot, and here we are.
That relates to there's a couple questions from some residents, some internal medicine residents. And besides thanking you for your conversation today, in what ways can internal medicine doctors best contribute to MSF since we do not have the surgical placements that fields like OB can do? And then the other comment by another resident is specifically says, what type of skill sets do you look for this kind of work?
Okay, so strangely enough, your clinical training will suffice. It'll be hard to get used to not ordering stuff and sort of, but that is part of where your local colleagues are really helpful. So as skill sets go, being a new person in a new place is the skill set that I need you to have. I would recommend doing locums to sort of get to show up at a place and simultaneously have them trust you, respect you, but also you still got to do your job. And that is a skill set. It is really hard. I've worked in places where women don't look up from their feet and I'm barking orders for the blood bank. Like being the new person in a new place is the skill set that I look for. The clinical training, you'll be fine. Most of what you'll need to learn is in the back of the book, the chapters you don't read anyways, but your local colleagues will sort of give you that. You know what you're doing. What you'll need to do is be able to adapt and to be able to adapt with some humility. That I can't tell you how many times I missed a diagnosis. I called a PE, I'm going to say a full 15 times. It was malaria 15 times. It was malaria. And my local colleague is like, no, I don't think so. And I'm like, oh, run this, do that. I'm pretty sure it's malaria. Just that you learn. So the humility of being a student again, after all these years of training, the humility of people calling you by your first name. MSF is a first name organization. And it took me a while to just get over it, to give away the thing I've been clawing for all these years, which is to be Dr. Stewart, and then everybody to call me Dr. Africa anyway. So some humility, some ability to adapt. And then as they always say, one of the best abilities is availability. In some ways, just being able to say yes when they call is a skill that you have to have the rest of your life in order. You have to be in a place where your colleagues know you'll come back if you leave for 6 months. You have to sort of be the sort of person that can say yes, and also be the sort of person that can say we and si, sanu. Like, in all those languages, in all these places, you will have to command respect and be respectful the minute you touch down. Those are skills I'm looking for.
Very nice. Dr. Kamthan made a comment that he started his career as an oncologist in Zambia, and asking how can he support your program. He has a very special attachment to Africa.
I share your feelings, sir. Ms. Pope, is the international report in there? Can they click on it?
I don't see that it's there.
Okay, I'm gonna figure. Oh, there. Okay, thank you. Thank you. All right. So the answer to your question is it's in alphabetical order. So scroll up, but you can click on all of them and get more information. But I would say, especially if your heart is in a special place, a lot of what we do is touching on local organizations. So that would be the first place that I go. Not that, please donate to Doctors Without Borders, so we welcome that. But I'll give you the party line. But the real, I think the piece of, if you're looking to have a hand in it, to feel that place of you feel, remember what the sunshine felt like on your skin. Support the local organizations that are NGOs that are struggling, because that is all the places where I can't get to. In some ways, MSF is too big for some of the smaller organizations. So we can work with WHO and work with the Ministry of Health, and we can work with some of the larger groups, but some of those small ones, I think, go under our radar, but still do a community a great service. And in some ways, that is what we're shooting for, is to be of service, not necessarily to be of, to have our hands in it.
Gotcha. There's a comment saying really powerful by Miriam Ford, and then talking a little bit about local health workers and how important the local is essential and how we need to do that better in New York. And then asking a little bit about, how the recruitments are, if they're short, like 6 weeks to 3 months, or how do they get organized in terms of if you do volunteer?
It depends on what you do. In some ways, continuity is better than a flashy new surgeon. So the priority goes to people who can do more like 9 months. But in surgical missions and specialty missions, I think you can expect a shorter time frame because you may be the only you. And it's just only so long you can just be on call and, sleep with the radio and the sat link, and I never know which one of them, or sometimes the driver will just knock on my tuchel and say, comms are down, the hospital is trying to reach you. You can only do that so long, just burning the candle at two ends. So the fewer of your kind, the shorter your assignment, because there may not, that is the soonest we can sort of get a replacement and some relief out to you. So I would say the closer you are to primary care, the longer the commitment will be, in part because those projects tend to need continuity, but also there are more of you. So, you can expect to be somewhere for a while, but have weekends and holidays and all of that sort of thing. It'll be more like a real job over that time frame, as opposed to, a surgeon flying in, a trauma surgeon flying in. I'm going to say our fistula repair clinics, sort of those higher, more and more specialized, the shorter it'll be.
Great. Here's a great question. So we are developing here, bringing back now post sort of pandemic, a lot of the tracks, the global health tracks and programs, and many of the residencies. So this question is one from one of our Med Peds residents. When developing a global health track program within a residency program, what are some specific things we can do to make sure we are creating a program that is also working on decolonizing global health?
So that, I'll say where my approach is, because in some ways I feel like the impetus to decolonize humanitarian care, I think, it stops us from doing the dignified care that still needs to be done in the meantime. So we're paralyzed by not solving colonialism yet. And I think the piece that I take with me when I'm working is the decolonization is the change, is a shift in the perspective and the shift of who is centered in that narrative. And in some ways, our goals of patient-centered care, community-centered care, is the antidote to decolonization. That the idea that we're going to show up and pass out the thing that you all need is entirely different than we are here to figure out how we can be of service. And that is certainly my approach in my leadership and my approach into the decolonization of humanitarian care at large. Is in some ways, when MSF does things differently, all of the sector does things differently. So when I tell you I'm bringing a sledgehammer to those notions, it's exactly that. Of we aren't staffed by British nurses that get flown in or American OBs that fly in for the most part. We are staffed by locals. We fly in folks that we need to, but to change that perception of what humanitarian care is to speak to that piece of decolonization, because it speaks to the expectations of the kind of care that we're giving. We are giving local, dignified, safe care in a way that this community demands. And to me, that is the antidote, or at least the counteroffensive that makes me still fight, because I don't know if I don't know if the goal of decolonizing humanitarian care will happen in my lifetime, but I want to use my time wisely. And I feel like that building the expectations amongst our beneficiaries of the kind of care that you should be getting, that you should be able to ask of your caregivers, that you should be able to question, that to me is the centering of a new narrative of who's in charge around here. And the we should be those of us that speak the local language, that we should decide what it is that you're delivering based on what we need.
I think that gets at the next question. I'll just read just to make sure there's nothing else you want to add. And the question was, how does MSF truly identify local needs of communities where they do not already find themselves? So I think that was what you just answered.
Yep. And that is the benefit of being 50 years old, is that in some ways we already are in a lot of places. What we need is to create a space for the locals to say, this, I'm trying to think of a good example. These COVID vaccines sound great, but people here are dying of malnutrition. Like, they're not going to live long enough to get COVID. So thank you very much. And also in the mountains, there's unbelievable sexual violence. And sometimes they just throw them away. You'll find them at the bottom on the rocks. Well, then shut down those ultra cold fridges. Get me one of those. We can get a jet full of those ORs that float up. Like, in that way, we are already local in a lot of places. We try to capitalize on that and just keep our ears open so that we are responsive to changes in the community. And I'd say that is by and large exactly what's happening in Malawi. So we started on they had a rare cholera outbreak 19, 20 years ago. So that's why we were there. And then as the AIDS epidemic blew up and cervical cancer blew up, they were saying that we keep finding these little ladies emaciated, having been dropped off or disposed of now that they are dirty or sick or broken. This is what our community needs. We need to be able to prevent this. And that is the beginning of a palliative care program. That is the beginning of a surgical stage. That is the beginning of radiotherapy. That is the beginning of widespread screening. That is the beginning of what do we do with the HPV vaccines? Like, all of that came from someone's throwing away the ladies in our community when they start to look this way. That is community-centered care. And that is how we identify the needs of someone says, what can we do about this? Like, now that the cholera is over, now that malaria season is over, sort of what we need around here, the ugly thing that we don't talk about, that we can't address. That's where MSF does really well.
There's a question, we're coming up near the end, but I think the question is a practical one about how you think about your staff. We spoke about sexual violence in the various countries and how you think about your staff and if they're become subject to sexual violence and how you take care of them and you think about that component of your program.
Well, I would say there's two questions in there, which is our duty of care to staff. And that is not just sexually based, but that is the violence of getting to work. In our Haitian projects, we have closed down a couple in the recent, because our staff just can't get to work. Like, the way to work is so physically dangerous that we have to question whether or not we're causing more harm than good. Is there another way that we can or should be doing this? In your question is that duty of care, which we deal with from 1,000 different angles in different contexts. But it is first on our minds, because in some ways, it is the mandate, not just in conflict. I would also say, and when we are dealing with natural disaster, that is another piece of sort of duty to care, which is I can get you in there, but I don't know what will happen with the aftershocks. We have to, it is my responsibility as your employer to make sure that piece of it is informed and you consent. The other part of it is just the context, sort of dealing with staff in a context that has violence in any form. And I think that is a slightly different than the duty of care, but just sort of the respect of the context. So we call it respect the roster. In a lot of places, the way we are staffed, like on an hourly, on a shifty basis, is absolutely worked around the tuk-tuks and the checkpoints. It is a schedule that wouldn't make any sense unless you overlay sort of the local piece of how transportation happens. So we are in a lot of ways, I think that every project answers that question differently. I think from a leadership standpoint, my goal is to make sure that they are allowed to, that you're not reading from a manual that's written in French from whenever it was written, sort of the gold standard of humanitarian care. I am absolutely fine if you use that for kindling to keep our staff warm when the power is out again, because in some ways that is the piece of colonialism of sort of assuming that the answer is in this book written by someone who's never been here. The truth is the answer is in a conversation that we got to figure out how to have. And sometimes that's the aunties, local leaders. In some places, when I was working in Puerto Rico during COVID, those people were social workers. They were absolutely keyed into the community. They had done it for a hurricane and Maria. They knew how to address the needs of their community. They didn't have the ability to negotiate for PPE because Puerto Rico isn't a state. So states that had a lot of money got it first. But I can do that, that's a community-based need that we can answer. So it all ties into what is it that you need, not what do we have that we can pass out or give away. And in Puerto Rico, what they needed was 2.5 phone calls. Like I didn't even have real pants on, and we solved that situation. You know what I mean? I didn't have to even put on my khaki boots. And so I think we are learning real time how much we can do with local support. And I think in the grand scheme of hindsight, we are learning very much that the community-centered pieces of our projects are the safest. When you have soldiers' wives and moms in your hospital, you won't hear more than a whisper. It's a quiet, safe place because we are a part of a community. So we're trying to replicate that over and over, and also trying to break away from our own bad habits of referring to the book or looking up something as opposed to looking into the eyes of someone who knows this place, who knows here, wherever here is.
Thank you very much. We've come to the hour and I just enjoy listening to you so much. It passed so quickly. I really want to thank you today for coming to visit us here. And really, you had a very wide breadth of people on the call. But really listening to your insights and how this is done was just phenomenal and great for our trainees to hear. And to see such a wonderful role model. So Dr. Stewart, thank you very much for coming today.
I'm glad to. Doctors.borders.org for those trainees looking for a job. I'd be glad to have you.
Perfect.
Steal you away from Sinai. My
That's
evil plot
perfect,
comes together.
Have a good day, everybody. Thanks.